Hi everyone. I wish I could be there in Maine and give this talk in Maine, but I'm out in Utah right now. We're in Park City, and I came across this young lady over here who unfortunately was off-piste a little bit, and looks like she's dislocated her shoulder. So I thought, well, what better time to show you how to put a shoulder in without sedation. So follow me. So I'm going to venture a guess at what happened to this young lady over here. What's your name?
Maya.
Maya. She was taking it a little too fast and probably fell on an outstretched arm. And she says that it hurts a lot when she tries to move it. And I asked her if she could reach over and touch her opposite shoulder with her right arm. And she says she can. Can you do it?
No.
She can't do it. It hurts too much to do that. I don't have an x-ray. I don't have any other way to figure it out. But it's going to hurt a lot more for this lady to go all the way down without the shoulder in. So we're going to try to put it back in for her. All right. So what I've already done is I've kind of palpated, and she's thin, and I can palpate and I can feel a little hole in the glenoid fossa here, and I can feel that the humeral head is anterior to the shoulder here. So this is anterior shoulder dislocation, especially the way she's holding her arm. And I've already felt the axillary nerve. Do you feel anything touching you there?
Yeah.
Does that feel the same as this side and this side?
Yeah.
All right, so we know there's no nerve injury there. It's always a good idea to make sure there's a good pulse there too. So we're gonna feel the radial pulse, and she's got a nice strong radial pulse, and we know that there's no axillary artery injury either. It's pretty uncommon anyway. So if we had an x-ray, we'd get an x-ray to make sure there's no fracture, but we don't have that luxury. The technique I'm going to cover today is the external rotation technique, and it's awesome because in the publications that came out with it, it showed that it's got a
more than 80% success rate
without sedation, which is what we need around here. There's no room for propofol. There's a lot of white stuff, but none of it is propofol. All right, come on closer so I can show you the details. All right, so first things first, what we're gonna do is we're gonna adduct. We're gonna bring the shoulder and the elbow here close to her chest. Is that all right? Can you tolerate that? All right. And then I'm gonna elevate the arm by 20 degrees. So we're gonna go up like this 20 degrees. Is that okay?
Yeah.
All right. And now, this is the part where we're gonna just gently externally rotate the arm. Is that okay?
Yeah.
All right, and you should be able to feel the, did you feel that pop?
Yeah.
Okay, all right, so don't move it too much,
Okay.
but that just popped right in. Now, can you show me if you can touch your opposite shoulder with your right arm? Can you touch it all the way up here? Nice. So if she can do that, this shoulder is in. Now, you're still not gonna ski with your pull. I'll help you carry your pull down,
Okay.
but at least it's not gonna hurt so much to go down.
Okay, thank you.
You're welcome. Woohoo! All right, so we are on the gondola, and I just happened to be sitting next to this poor kid, and Mom just told me that he's dislocated his jaw before when he yawned. Oh, we're going over some sound. When he yawned too aggressively, and it sounds like he did it again. Did you yawn aggressively again? And he can't speak. So my guess is that he's got some laxity of the ligaments in his TMJ, and his posterior condyles of his jaw have gone stuck anteriorly. So there's lots of different ways to dislocate your jaw, but the anterior jaw dislocation is the most common we're going to see in the emergency department. All the other ones, the lateral one, the posterior one, the superior one, all those are related to significant trauma. You know, like a significant uppercut, or like, you know, big fall, stuff like that, or a big hook to the jaw. Those will cause all the other fractures and dislocations. But this is not a fracture dislocation. He was just yawning, and he can't close his mouth. And the reason he can't close his mouth is because the condyles are stuck in front of the tubercle. And I'll show you a little picture of this when I get home and edit this. So to fix this, all we have to do is two things. One is to decrease some of that tension on his masseters and his pterygoid muscles that are keeping this from going back in. And two is put some downward pressure and then forward pressure so that it pops up. Now, I've seen people do this, and in YouTube videos you can see of people giving propofol and sedating patients and making them completely loosey-goosey for this. And it's probably the worst thing you can do, because then their head is bobbling and you're trying to put it in and their head is bopping, and it's not a good idea. So what I recommend doing is actually having him sit against something hard, and he's got his helmet and he can lean against the plexiglass here. And what I'm going to do is I'm going to stand in front of him to leverage my weight, and at the same time, now if we had a nurse or someone who could help, like even his parent, but the parent right now is shooting the video, so if we had someone to help do some master massage, that would really help. So Max, right? Can I take your gloves off real quick? Can you give yourself a massage like this over the, right here, like right here, these muscles here. These are the strongest muscles in your face, okay? All right, and what I'm gonna do is I'm gonna come from here. I don't have any gloves, so I'm sorry, buddy. I'm gonna stick my dirty hands in your mouth, but that's just the way it goes. All right, lean back a little bit. Shoot it from the side so they can see the angle here. All right, so keep massaging yourself. And the beauty of this is this just happened, so the sooner you do it, the less. All right, we're gonna push downward. I'm gonna use my leverage here, and I'm gonna push forward, and boom. Look at that. Nice. All right, so there it is. That's the jaw dislocation reduction. That's the anterior jaw dislocation. It was not related to trauma. It was some sort of laxity he's had. He's dislocated it before. He yawned too hard, and it popped back in. Down, forward, and master massage the whole time. And probably the best part of it was we did it as soon as it happened, so that all that spasm wasn't happening. All right, next we're gonna talk about how to rescue your own shoulder dislocation if you're out in the woods. All right, well, it actually happened to me. I was hiking, and I just dislocated my right shoulder. And it's the right shoulder because most people are right-handed, and that's the most commonly dislocated side. So in this particular scenario, I'm out in the woods alone with my wife, and I'm gonna try to put this shoulder back in with her help. And so this is a good one for wilderness medicine, especially if it's you and someone who's non-medical. So what we're gonna do is we're gonna talk about the Davos technique. It's called Davos because the physician who initially described it was from Davos, Switzerland. And there have been multiple publications on it, and depending on which one you believe, it's either 60% or 86% effective. But I'll take those over having to hike out of the woods with a dislocated, painful shoulder. And again, remember, the sooner you put it in, the better, because the muscle spasm hasn't set in. So the first thing we gotta do here is we gotta get my shoelaces off so I can tie my wrists. So if you wouldn't mind helping me with that, I'll take my shoelaces off. All right, so we've got the shoelaces out, and so what we're gonna try to do is just tie my wrists together. And the reason you gotta tie the wrists tight together is because you can't lock your hands together and put it around your knee, because if you do that, you're actually engaging a lot of muscles, and it sort of like prevents you from loosening and getting these muscles relaxed. All right, so what I'm gonna do next is I'm gonna bend my same side knee and try to hook my hands around it. And now I need some counterweight, so if you can just stand on my foot so that I can lean back. And I'm just gonna gently use my weight and just lean back like this until at some point there's enough muscle fatigue and the shoulder pops right in. And that's how you can reduce your own shoulder when you're out in the woods by yourself with someone who can stand in front of you. So to review, we talked about the external rotation technique. That's when you abduct, you forward flex 20 degrees, and then you're gonna externally rotate. We talked about the jaw dislocation, the importance of the masseter massage, and then you're gonna push down and forward. And we just covered the Davos technique, a way to put your shoulder back in. So that's it for now. Thank you so much for your attention, and see you out on the slopes. My kids were not hurt during the making of these videos. All right, so I'm going up the gondola, and I happen to be next to